Good morning for all. My name is Ayed Bani Bakr. I'm critical care unit team leaders. And I'm working in Sultan Qaboos Comprehensive Cancer and Research Center. So in this presentations, I will discuss about rare case report admitted to our unit, which is 5FU related encephalopathy and status epilepticus. In this presentation, I will talk introduction about chemotherapy 5FU. Also, I will present patients' information upon the admissions and the clinical finding, what we found, and therapeutic intervention that have been done for the patients during his ICU hospitalizations, and follow-up and outcomes for the patients, and discussions for the patients. And also, I will talk about treatment modalities that suggested in literature regarding such cases of 5FU. So as we know, 5FU is an anti-metabolitic agent and antineoplastic agent that has been widely used as adjuvant chemotherapy for a variety of cancer, such as carcinoma of the breast, pancreas, colon, rectal, and the stomach. Also, 5FU has been widely as adjuvant treatment in different cancers, in adjuvant setting and metastasis setting. The common side effect of 5FU, it's gastrointestinal toxicity, including nausea, vomiting, diarrhea, and stomatitis, as well as myelosuppression. Additionally, hand and foot syndromes and coronary vasospasm. But there's rare side effect for 5FU. About 5% of the patients who are receiving 5FU have been reported to experience neurotoxicity syndrome, which describes in literature hyperammonia encephalopathy, Waring's encephalopathy, and cerebral type syndrome, and subacute multifocal leukoencephalopathy. In critical care units at Sultan Qaboos Comprehensive Cancer Care and Research Center, we reported a case of patients who developed acute neurotoxicity presenting with severe encephalopathy and recurrent seizures. So this patient, he's 51 years old, male patient with history of hypertension, diabetes mellitus, and chronic kidney disease with estimated glomerulus filtration rate 12.5. The patients underwent EGD related to epigastric pain for 1 year durations. The results of EGD shows 10 centimeter by 5 centimeters mucosal lesions. The biopsy results revealed invasive adenocarcinoma. There was no evidence of metastasis disease. The patients underwent subtotal gastrectomy with D2 dissections. The histopathology results from the biopsy showed poor differentiated adenocarcinoma with TNM stage PT1P N1 M0. The patient was commenced on single agents 5FU in adjuvant setting due to high comorbidity and low glomerulus filtration rate. The chemotherapy dosing was followed based body surface area. It was 1.74 per square meters for the patient's body. First, calcium folate giving 400 milligram per square meters from his body, then 5FU IV 400 milligram per square meters for his body surface areas, followed by infusion. 2,400 milligram per square meters. So the patients received total dose 4,186 milligram. It was infused during 46 hours. After 6 hours of completion chemotherapy, the patients developed altermentation and seizures. The family of the patients transferred him to our hospitals, where we admitted him to ICU. Upon the admissions, the vital signs were stable and the patients were in room air. The patient was drowsy with equal and symmetrical pupil reactions. He was actively seizing with intermittent right-side neck turning and tonic-clonic seizures lasting for a few minutes, for a few seconds to minutes, with no regaining of consciousness in between. We did lab test for him. We showed that creatinine level, it was elevated. It was 300 39 millimole, and C-reactive protein, it was elevated, 82. The results of complete blood count, serum electrolyte, glucose and ammonia and thiamine, and blood pH and liver enzymes were normal. Other examination results were within normal range. Chest X-ray and CT scan without contrast were unremarkable findings. Lumbar puncture have been done for the patients. CSF gram stain and culture were negative. Acid-fast bacilli and fungal smears along with CSF viral screening were negative. CSF paraneoplastic antineuron antibodies were negative. Autoimmune encephalopathies, it was not present. Serum paraneoplastics antineuron antibodies and serum autoimmune encephalitis antibodies were negative. The DPUD genotype was intact. MRI results. The MRI result shows hyperintensity single lesions involve bilateral thalami and along bilateral cortex of occipital lobes and hippocampus. It was seen in two-way T2 weighted MRI. This is the results of a primary MRI for the patients among hospital admissions. As you see, there is hyperintensity lesions in thalamus. Additionally, EEG have been done for the patients. The EEG results reveal multiple electrographic seizures arising from left temporal occipital region. During the patient staying in ICU, he managed in line with refractory status epilepticus. He was initially intubated and sedated, and multiple anti-epileptic medication started for him, which is levotiroms, valproate, luxmide, and topiramate, along with IV thiamines also started for him. Later, IV methylprednisolone was given for 7 days. Along with the course of treatment, the patient's electrophysics seizures was controlled, and EEG shows diffuse slower background activities. 2 weeks post-admission in the ICU, the patient shows mild clinical improvement in terms of his consciousness level, and he extubated and remained seizure-free. After 9 weeks of initial presentations, IV methylprednisolone started for him and IVIG giving for 5 days. The patient has shown improvement in his consciousness level and comprehensions. His disorientations improved over time during his hospital stays. The patient was physically rehabilitated and improved and showed and discharged home. 2-month follow-up in outpatient setting, he was functionally independent, alert, oriented, with minimal memory impairment. A brain MRI showed partially improvement in hyperintensity lesion that was present before. And this is the results of MRI after 2 months of complications. As you see, there is improvement in hyperintensity lesions, what was present before. So this is before, and this one after. So as we know, 5FU penetrated the blood-brain barriers and can result in neurotoxicity, which is uncommon side effect with a described incidence of 0.6% that could be acute or delay reactions. Acute neurotoxicity usually presents with hyperammonia encephalopathy, Waring's encephalopathy, and cerebral type syndromes, and delay neurotoxicity manifests as subacute multifocal leukoencephalopathy. A clinical report of status epilepticus related to our case, it's not seen all of these presence with the patients. Also, the exact mechanism that underlie the various the neurotoxicity is poorly understood. Several theories have been proposed, including Krebs cycle suppressions caused by fluorocytates, which inhibit the adenosine triphosphate-dependent urea cycle, causing hyperammonia and lactic acidosis. But that one, it was not present in our patients. It describes in literatures as a BDB deficiency. BDB is as an enzyme responsible for a breakdown of 5-FU, and its deficiency leads to 5-FU accumulation with neurotoxicity effects such as demyelinations and increased cellular thiamines metabolism, lead to Waring's encephalopathy-like manifestations. The diagnosis of 5-FU inducing encephalopathy, including the development of encephalopathy during or shortly after 5-FU administrations, along with exclusion of metabolic, somatics, and drug reactions. The different side effects might happen, such as stroke, encephalopathy, central nervous system infection, and psychological disorders. There are several treatment modulators have been proposed in literatures. It's ranging from supportive measures to use of corticosteroids, plasma exchange, and thiamine. The mainstays of treatment remains withdrawal of 5-FU. Uridine tricetate, the antidote of 5-FU, has been proposed as a treatment for severe 5-FU toxicity and should be considered in severe cases with dihydropyramine dehydrogenase deficiency. So in conclusion, 5-FU related encephalopathy is a rare potential deliberate side effect. The patients can present with different stage of altered sensoriums. The presence of hyperammonia could lead to the diagnosis, but a normal level of serum ammonia does not exclude the diagnosis. So if the patient is not present with hyperammonia, we can say this is not complication for 5-FU. It is important for oncologists and the neurologists to remember and understand this morbid side effect. So the promote diagnosis is made with 5-FU withdrawal and supportive treatment is ensured. Okay, thank you. Thank you for listening. And I am ready to receive any questions.
Okay, thank you. How are you? Good morning. I'm very glad to share with you my abstract, blood bottle and balance, and the hematology story of chemotherapy in Sudan, women with breast cancer. My title is about the evaluation of hematological parameters pre and post chemotherapy in breast cancer patients at the National Cancer Institute in Sudan, Khartoum State, Sudan. My name is Dr. Rehab Muhammad Al-Madina. I'm Associate Professor, Medical Laboratory Science, Hematology, and I work at Inaya Medical College or colleges, MLS program, KSA. The global and local context, the breast cancer is the most common malignancy among women worldwide, and in Sudan, it ranks 15th among leading causes of death, as said WHO citation 2022. And late diagnosis contribute to higher mortality rate, as we know. Burn tumors, the blood tell about the chemotherapy target malignant cell, but harm the bone marrow. And this leads the bone marrow suppression, which lead to anemia, leukopenia, and thrombocytopenia, what we call pancytopenia. Each patient's plot reflects a unique balance between healing and harm. Our objective is to evaluate the hematological change induced by chemotherapy in Sudanese women with breast cancer. And our study design is a case control study conducted at the National Cancer Institute in Khartoum. We have about 100 participants, 15 cases and 50 cases and 50 control. We held blood samples pre-chemotherapy, 15 blood samples, and post the first cycle of chemotherapy, and we have a healthy control. CBC analyzed using seismic XCB 300. Data as witness, as we call, our study at the National Cancer Institute in Khartoum is more than number, and it is testimony. So far, before chemotherapy, the red blood cells count was reduced from the control, as you see, and white disease was increased than the control, and platelet was increased, and that is all before the chemotherapy. After chemotherapy, RBCs was reduced from control, and white disease also was reduced from 4,000 to to 4,000, and platelet also was reduced, and this lead to pancytopenia. Is very clearly observed in most cases. Each data point is heartbeats, breath, and risk. So far, chemotherapy damage bone marrow, reducing blood cell production, and which lead to cause anemia, immunosuppression, and bleeding risk as the platelet is reduced and cause thrombocytopenia. And finding a live study in India, Nigeria, and Ethiopia. Same study about Sudan perspective. Limited transfusion and monitoring resources is very crucial. Highlight the need for regular hematological monitoring and supportive therapy. And we have to envisage local healthcare adaptation. Our recommendation is very important and very crucial to monitor CBC before each chemotherapy cycle, and very important to use erythropoietin and growth factor when available at therapy. And also we have to strengthen awareness and yearly diagnosis campaigns. And also we have to encourage the multi-center study across Sudan and multi-research. And our conclusion is that the chemotherapy significantly reduces RBCs, white BCs, and platelet, and continuous monitoring ensures safer treatment, and every data point represents a life, every cell counts. Human reflection, our body or our blood remember every battle and every patient. Science meets survival. Let compassion guide our data, drive and care, and this is very good. And I'm going to acknowledge the National Cancer Institute in Khartoum, Khartoum Oncology, Hospital Sudan, Inaya Medical Colleges, KSA, and this is my email. And final word, thank you for walking this journey with me, and from ability to vulnerability and toward resilience. May our collective insight help restore balance to the bloodstreams of those we serve. This is my paper citation. The work was carried out in collaboration among all authors, and this is the QR of the paper, and you can return it. And thank you very much for your time.
Yes, hello everyone. I'm Sumaya Anwar from Cancer Genetics and Epigenetics Lab from Concept University, Islamabad, Pakistan. And topic for presentation is PFKP mediates metastasis through altered glycolysis in breast cancer. We talk about the breast cancer. Breast cancer, everyone know, is the highest incidence and mortality rate, and it remains the most common diagnosed malignancies in women and leading cause of cancer in worldwide. But according to WHO and World Health Organization, 2.3 million breast cancer cases diagnosed and 6,85,000 deaths were reported in women. And in figure, we can see that in 2022, like 43,000 women and 530 men die due to breast cancer, reported as 2022. And 68 lakh 84,996 deaths as we report here in 2020. And interesting thing is 69 years is the median age of death from breast cancer. So a recurrence from 20 to 30% women treated, and its survival rate 3.8 million in the history, and every 30 minutes one woman dies due to breast cancer. And in the US, lifetime risk for 1 in 8 for every woman. And metastasis is the point where from clinically outcome invasive breast cancer and 90% of cancer related to death because of the metastasis. And here we mention about the Warburg effect and reprogramming or metabolic reprogramming in cancer, in which shows that breast cancer primary site, and here breast cancer invade and move to as circulating tumor cells from the vascular by the enhancement or increase effect of fatty acid oxidation, Warburg effect, and increase the pyruvate and lactate, which increase the glycolysis and breach the blood-brain barrier and move to brain cells. And high glucogenesis, serine synthesis, and lipid adjustment provide the high energy to survive the cell in the to survive the tumor cells in this microenvironment. And we need for the target therapies, and current treatment do not effectively predict metastasis as at early stage, so new prognosis and new markers are required. So PFKP is the gene that highlights not only the glycolytic but also the hypoxic condition of in glycolysis pathway, which mentions that breast cancer leads to metastasis involve this gene. And this is the critical enzyme involved regulating the glycolysis and play an important role in metastatic transformation in breast cancer cells. And here we can see that this figure show that HIF1, this one gene HK2 hexokinase, one enzyme which leads next to PFKP, and this one how can play a role in the breast cancer. This cell is the tumor associated macrophages, and these provide the GLUT1 source of glucose, source of energy, and convert glucose into and next again hexokinase convert into pyruvate and then lactate, and this lactate high production of lactate produce high glucose and ATP production, which enhance the EMT situation of from breast cancer to leave and breach the barrier and move to vascular to the lungs and brain metastasis from breast cancer. And PFK role in breast cancer metastasis, this one is the rate limiting glycolytic pathway enzyme from downstream to HK2, and overexpression of this gene in pathway shows that upregulation and in not only the breast cancer but also in the glioblastoma already reported but not clearly mentioned the metastasis role. So this study investigates elevated PFKP expression contribute to breast cancer to metastasis, which promote not only the glycolytic flux but also the tumor environment as hypoxia. So objective of study is to evaluate the role of PFKP in mediating breast cancer metastasis through glycolysis pathway, and identify the differential express gene through the multiple microarray datasets. And the next, analysis of prognostic significance of PFKP expression in breast cancer and association with the clinopathological features. And next one, explore of PFKP as a productive biomarker for the metastasis. This is simply workflow shows that we take 4 data sets, 2 are assigned as the discovery cohort and next one for the validation cohort to check the results are similar or inconsistency. For these datasets shows that 38 primary breast tumor here, 94, 66, and 265 sample size of breast tumors. And these are the clinical data mentioned that metastasis age, ER, PR similarly. And 2203 DEG against metastasis we find here from and similarly other data sets, and we go for the statistical analysis and check the also association of other similar genes, common genes CCDC6, PKIA, PFKP, and UACA, these 4 genes with clinical features, and go for the gene analysis and check. We find a common pathway is the glycolysis pathway, and we find that correlation of significant more genes ENO1, GM1, LD, HB, and PGK. These are the genes which are downstream to PFKP and play important role in the upregulation of expression in metastasis. These are some clinopathological parameters of discovery and validation cohort for metastasis, age, ER status, and PR status, and these are the number of patients mentioned in different parameters. So what are the findings? We go for the differential gene expression and significant genes and their association in breast cancer reported here for cohort 1 and 2, like these 2 data sets, and these are the DEG numbers. Only 34 are the common DEGs, but from 34 we found only common DEGs are these 4, which have high expression upregulation of metastasis either than primary tumor in both datasets, dataset 1 and dataset 2, and also check the association with the PFKP, CDCC, PKI, and UCA, and it's mentioned that in discovery cohort, this cohort shows the highly significant and correlated with PFKP and metastasis. And next, we go for the validation cohort and discovery cohort combine it. When we check, we find only one gene that is highly significantly highly expressed in all the cohorts, and so we select the PFKP gene is maybe the biomarker for the metastatic and next therapies for early detection. Like here, we check primary in next data sets, primary tumor and metastasis. Yes, metastasis is significantly highly expressed in both data sets. So these are the clinical parameter analysis of significant common genes, where we select, as we mentioned, 4 genes are selected, PFKP, UACA, which are consequently again repeated in the different data sets. And these are clinical parameter ER, Ki67 shows that the downregulation, but in the metastasis, you can see that it shows the upregulation. And here, similarly, other data sets for the metastasis, you can see all of the genes mentioned here, these all are upregulated in metastasis for breast cancer in all data sets. Next, we also collect the data from breast cancer patient from PIMS and Holy Family Hospital, and this was 100 patients of breast cancer patients, and we check the primary normal data, primary tumor data, and metastasis, and we do the expression analysis with qPCR. And to see that the metastasis is highly significant and more highly expressed than normal and primary tumor. And similarly, we go for the Ki67. This one is the proliferation marker that the data is already available in the clinical pathological data. And this also shows that Ki67 is highly significant and more in the metastasis form. And when we go for the predictive biomarker for ROC under curve, then we see that Ki67 has more 76% of results, but in the PFKP expression 66. So PFKP, it's mentioned that it's Ki67 is proliferation marker. This shows that metastases are high in breast cancer. We also go for the survival analysis and see that the at primary PFKP with downregulation and upregulation, it shows that worse survival, but in the metastasis, its condition is poor survival, and even one death we take one death from this data, and this shows that the primary PFKP expression and primary tumor expression with the metastasis. And these are the association of the clinical pathological of data which we obtain and collect the sample from the PIMS Holly Hospital of breast cancer patients. And here age, tumor size, clinical stage, grade, carcinoma histology, nodal involvement, metastasis, menopausal status, and treatment therapy. All of these shows that we have collected normal samples, control samples, and tumor samples 100, but all shows that PFKP show significant in all the samples, and tumor grade and metastasis. They are more significant than the other relevant clinopathological factors. And we go for the after that we go for the enrichment analysis. In enrichment analysis, we find that these are the different pathways which are highly significant, as we can see 0.00. So here is the most significant is like pyruvate metabolic pathways. All are metabolic pathways, but mainly glycolysis and glucose pathway. And next one is we go for in the second one with gene enrichment analysis for hypoxia condition. We can see that hypoxia is the more highlighting pathway. So PFKP is not only play role in the glycolytic but also the hypoxia pathways. So enrichment plot, we here mentioned that PFKP have highly significant value in the plot. And in this plot, this is made by cytoscape glycolysis pathway. These bars are mentioned that this condition at normoxia, and this one is the hypoxia, and we see that hypoxia is more in, you can see in the figure like the small bar and large bar, hypoxia is more in relevant and related to this condition or with PFKP and glycolysis pathway. And next we check the co-expression and association of other glycolytic genes which are downstream to PFKP. Here we can see that these PFKP2, PGK1, PGM1, INO1, and LGHP, these all are also associated with the metastasis and primary tumor genes. Like we can show here, these data show the significant results of highly expression and association show positive in also in the discovery and validation cohorts. So the key findings are PFKP is upregulated in breast cancer metastasis, altered glycolysis, and also play role in hypoxia, and high expression with correlates with poor prognosis and metastasis potential, and it's also potential as predictive biomarker. But for the future direction, we can go for investigate the therapeutic strategies for PFKP to detect the early detection of metastasis and also improve patient outcomes to prevent metastasis. So these are the references. Thank you. If you have any question, you can ask, please.
Good morning, everyone, ladies and gentlemen. My name is Dr. Mohammed Hussein, Assistant Professor of Biochemistry and Head of Research Support Unit at Dubai Medical College for Girls. Today, inshallah, I will share some insights and discuss our poster, which titled Precision, Regeneration, and Parkinson Disease, with a focus on application of CRISPR and epigenetic remodeling and stem cell-based therapeutics. Actually, this poster represents findings from recent PubMed indexed trials exploring gene-targeted approaches for neuroregeneration. Let us begin with a brief overview of Parkinson's disease. As you can see here in this slide provides an overview of Parkinson's disease. As you know, it's a progressive neurodegenerative disorder, primarily affecting dopaminergic neurons in substantia nigra. Its pathogenesis, as you know, involves abnormal protein aggregations, particularly of alpha-synuclein, encoded by the SNCA gene, as well as mitochondrial dysfunction linked to genes such as BINK1 and VPS35. Despite advances and progress in symptomatic therapy, there remains critical need to regenerative and disease-modifying strategies, With this context actually in mind, let's consider the molecular tools that have enabled such targeted investigations, beginning with gene editing. As you can see here in this slide, this introduces gene editing as a transformative biotechnological platform, enables scientists for precise and targeted modifications of genetic sequences. So this technology, as you know, researchers can model pathogenic mutations, correct defective alleles, and evaluate therapeutic gene modulations. Our focus in Parkinson, as you know, so in Parkinson research, gene editing has been instrumental in studying mutations in SNCA, BTB1, DNA GC6, and BI, NK1, among others. We now turn to CRISPR, the most powerful and widely utilized gene editing system. As you can see here in this slide, summarize the operational mechanism of CRISPR-Cas9 system. As you know, it functions through three principal stages. Stage 1, adaptation; 2, expression; and last one, interference, allowing RNA-guided recognition and cleavage of specific DNA sequences. As you know, Cas9 acts as a molecular nuclease, introducing double-strand breaks that can be repaired to achieve precise genetic modification. So this system has been used, for instance, to silence the pathogenic of mutations in genes like SNCA, A53T. So by reducing toxic alpha-synuclein accumulation. So this mechanism of action can be utilized to modify genes in Parkinson's disease. This our methodology. This slides outlines the methodology of our literature review. We have conducted search of PubMed databases focusing on studies published within the last 5 years, actually. Inclusion criteria comprised original research, utilized Cas9, or related gene editing systems in Parkinson's disease models, both in vitro and in vivo as well, with reported molecular or functional outcomes. The key search terms include CRISPR, Parkinson's disease, some genes like SNCA, BI, NK1, and stem cell based, for sure, stem cell based regeneration. Now let's us examine the range of experimental models described in these studies. Here, this slide illustrates the various experimental systems employed across the reviewed studies. CRISPR-based approaches were applied in mouse models carrying the different mutations of genes to replicate dopaminergic deficit, and in non-human primates with different deletions in some genes that reproduce hallmark features of neurodegeneration. Furthermore, human-induced pluripotent stem cells and three-dimensional brain organoids harboring some mutations that have been developed in models. So identified the models, we now turn to principal molecular target investigated. Here our result, as you can see. These different models, as explained, human model, rodent models, and cell lines as well. So what about this slide? Yes, different models. Here. So what about the target molecules and pathway? This slide highlights major molecular targets modulated in reviewed literature. For example, SNCA gene was the predominant focus given its role in alpha-synuclein aggregation. Other key targets include PI-NK1, which regulate mitochondrial quality control, another genes like NDU-SF2 involved in oxidative phosphorylation, and PTBP1, a factor implicated in astrocyte to neuron reprogramming. So these targets represent crucial pathway underlying neural degeneration and regeneration. Now let's consider the mechanism by which these genetic interventions were implemented. This slide gives us like summary about the principal interventions strategies identified. Many studies employed CRISPR-Cas9 mediated silencing to down-regulated genes like SNCA expression by reducing alpha-synuclein burden. Other utilized gene knockout or base editing approaches target BINK1 string or VPS35 to restore mitochondrial and autophagic homeostasis. Additionally, CRISPR-engineered stem cells were designed to secrete neuroprotective factors such as SRAGE, enhancing dopaminergic neuron survival. Okay, now move to the main outcomes reported across these studies. This is a brief findings and outcomes. The summary collective findings from different trials. Gene silencing of SNCA consistently resulted in reduced protein aggregation, which improved mitochondrial integrity and enhanced neural viability. Restoration or modulation of BINK1 expression improved mitophagy efficiency and protect neurons from oxidative stress, while BTPP1 suppression produced variable results in astrocyte to neuron conversion. Most studies demonstrate significant neuroprotective and regenerative effects. Nevertheless, limitations remain concerning long-term safety and delivery efficacy. Finally, let us conclude with the key implications of this findings. In conclusion, our systematic review underscores the transformative potential of CRISPR-based and stem cell-mediated interventions in Parkinson's disease. Targeted genes, especially SNCA, PINK1, and VPS35, represent a promising avenue for disease modification and neural restoration. Of course, future research must focus on optimizing delivery systems, ensuring genomic safety, and translating preclinical success into human trials. Thank you for your attention.
Hi, thank you so much for the introduction. Just trying to get my screen to be full. Okay. So, hello everyone, my name is Samar. I am a recent medical graduate from St. George's University in Grenada. And my topic for today is a case report that I worked on with another medical student here in Dubai. It's on cutaneous metastasis with squamous differentiation in triple-negative breast cancer. So, introduction, as we all know that triple-negative breast cancer is an aggressive subtype of breast cancer that lacks the three receptors that we normally look for: estrogen, progesterone, and human epidermal growth factor receptor 2. And unlike other cancers, this is a more rare form of cancer. It's responsible for only 15 to 20% of all the breast cancers. We know that invasive ductal carcinoma is very common. So triple negative, on the other hand, is not as common as the other forms that we see. And it's typically observed in young African-American women and Hispanic women who carry the mutation in BRCA1 gene, and it's associated with higher rates of recurrence and mortality, especially in the early years following the diagnosis. So with the purpose of this presentation, we're going to focus on cutaneous metastasis, which is a recognized complication of breast cancer, but it's not so commonly seen in breast cancer because you would usually expect people to have breast cancer spreading to the bone or the brain or lungs, but skin metastasis is something that's not always seen. And there was a study that found that skin metastasis was present in 42.4% of hormone receptor positive breast cancer, versus in triple negative breast cancer, only 23.2% of people had skin metastasis. So that just shows that cutaneous metastasis is less common in TNBC. And if it appears, if you have TNBC and then you have skin metastasis, it means that your prognosis is usually poorer and it's more aggressive. Your disease is more aggressive. So that is what we found in this patient. So this is a case of a 63-year-old female from Syria with a known history of metastatic TNBC, initially diagnosed in Syria in October 2023, and eventually she developed skin and pulmonary metastasis, which happened in July 2024. So in the beginning of this presentation, whatever I mention is things that had happened to her in Syria. And then when we see her, it's already progressed to a point where, whatever you do is most likely going to be palliative. But the first few slides are talking about her care in Syria. So she was diagnosed with triple negative breast cancer in October 2023, and she was started on neoadjuvant chemotherapy of doxorubicin and cyclophosphamide for 4 cycles, and then she also received carboplatin and paclitaxel for 6 cycles. And this went on from 2023 October till 2024 April. And then in May of 2024, after her, chemotherapy cycles, she underwent a bilateral mastectomy and a right axillary lymph node dissection. And then they did a pathology, they run pathology on that, and they found that she indeed has triple negative breast cancer. And then they started with capecitabine, 1 cycle of capecitabine. And then in July of 2024, again, all of this is happening in Syria. So in July of 2024, she developed new skin nodules for which she underwent a chest wall biopsy, and reports at the time showed poorly differentiated cancer with squamous metaplasia. So because of this, she received 15 fractions of radiotherapy, followed by her capecitabine and vinorelbine from September 2024 to November 2024. And they also did CT chest, abdomen, pelvis to see where her disease was at, and it was positive for multiple pulmonary nodules. So because of that, she was also started on gemcitabine in December 2024. So because of the initial care was done in Syria, we don't have access to a lot of her records, so we don't have her path reports, but these are the images that we took when we saw her in the clinic in Dubai. And you can see that, this is how her skin metastasis looked. This is from her left posterior chest wall, and you can see that there are firm nodules. Some of them have joined each other. There's some amount of scaling. They're very red. And this is how her metastasis to the skin looked like. And this is, of course, her pulmonary nodules. This is an axial CT scan showing these are the pulmonary nodules that we see. Again, this is just a coronal CT, and then you can again see the pulmonary nodules. So this is where we saw her. So in Jan 2025 is where she presented to RED and in Dubai, and she had high-grade fever and foul-smelling discharge from her wound on the right chest wall. So she already had that metastasis. She was already receiving treatment, and then she came to RED, and now she has a fever. She has this discharge from her wound, and at that time we ran some labs. We found her inflammatory markers were elevated. Her cultures were positive for these three bugs: Staph aureus, Klebsiella, Acinetobacter. And so we admitted her under the care of general surgery. She received IV antibiotics, wound care. She was monitored in the hospital. And then after 5 days of admission, she was discharged. She improved, so she was discharged. And during this period, of course, she was receiving her standard chemotherapy, which was the third cycle of gemcitabine. And then in Feb 2025, which is a month after her admission, she came to us again in the ED. She had worsening shortness of breath, and she had productive cough, brownish sputum, poor oxygen intake, all of these things. And so we did a chest X-ray, which showed that she had a left-sided pleural effusion, and she had a mediastinal shift to the right. So essentially, she had malignant effusion. So we admitted her. We did a pleural drainage, and 800 ml was drained. And then she developed pleural effusion on the right side, and that had a leftward mediastinal shift. So we again did, pleural drainage. We did wound and sputum cultures, and that grew Pseudomonas, and it was carbapenem resistant. So we started her on appropriate therapy. So this is her X-ray. She had you can see that there's a very big left-sided pleural effusion, and she has a mediastinal shift to the right. And then eventually it moved to the other side. So there became a right-sided effusion, and then there was a mediastinal shift to the left. So this is what was basically happening with her. It was going left to right, left to right. So it was recurrent. So at the end of March 2025, finally, she showed some amount of gradual improvement, like clinical improvement. So she was hemodynamically stable, afebrile, weaned off oxygen. We still continued her supportive care, and we, did all of these things for her: physiotherapy, prophylaxis, and we were on plan of ensuring that she's going to be discharged. She was ready for discharge, and she's going to have follow-up with outpatient, but her symptoms returned. She had altered mental status, increased shortness of breath, and at that time, the ABG showed that she had CO2 retention, and then the right-sided effusion, it became worse, and it became worse quickly. So we admitted her to the ICU for monitoring, but this is the time where she went into bradyasystole, and CPR was done, but we were not able to get her back. And so unfortunately, all of this led to her death in April 2025, which was a month after she recovered, and then within a month she passed away. So from this presentation or this case report, what we're trying to say is that cutaneous metastasis from breast cancer is uncommon. It's not something that you always see, and it's something that I personally haven't seen before. I've worked in the US for 2 years, and this is the first time I've probably seen someone with skin metastasis from breast cancer. And a quick search showed that reported incidences ranging from 0.7 to 10.4 among all carcinomas, which is a low number. And I can't say that cutaneous metastasis is the reason why she died, is the reason why this patient died, because there are a lot of things that went wrong with her. But it definitely signifies a worse prognosis and a more aggressive disease. It also, how does it present? It presents on the chest wall. It's often firm, flesh-colored to red nodules, and it can occur at any stage. It can be stage 1 or it can be stage 4. But if it's present, it often indicates that it's a very advanced disease and it's associated with a poor prognosis. And this presentation, cutaneous metastasis with squamous features in TNBC, is exceptionally rare. And clinically, it can sometimes look like a normal skin condition, and that can lead to misdiagnosis or delayed treatment. That's why it's important that as doctors, we always maintain a high index of suspicion. And if you see something and you know that this patient has cancer, it would help to probably look into it further. And one thing that we could do is routine skin checks during oncologic visits. Patients should also be educated on self-monitoring for new skin changes, such as any rashes or nodules or any erythematous lesions, as this can help with prompt diagnosis. And another thing to note is that management is challenging, because what can you do? If you have such widespread skin lesions, what can you do about it? You can't cut the entire skin. So usually there's a lack of standardized treatment protocols, which makes it even harder to treat. You can do systemic therapy, but it frequently resists. Cutaneous metastasis frequently resists conventional chemotherapeutic agents. You can try surgical excision, you can try radiation therapy, but sometimes all of these methods are just palliative. So that is one of the reasons which makes it so hard to treat. And the studies have also shown that the median survival after the diagnosis of cutaneous metastasis from breast cancer is approximately 13.8 months, with half of the patients passing away within the first 6 months. So this patient had actually passed away within 8 months of her diagnosis of skin cancer, skin metastasis. So this again just highlights how aggressive this part of the disease is, and the need for early detection and intervention. And we also need more research into what could, what is the reason why some people have skin metastasis versus some don't. And if, someone ends up developing it, what can be done to help them, or what can be done? How can we standardize treatment protocols? So again, for conclusions, it is cutaneous metastasis with squamous differentiation is rare, and it's an aggressive presentation of all breast cancers, and even more rare in triple negative breast cancer. And it often appears within months to few years of initial diagnosis, and it frequently coincides with visceral metastasis, which means organ metastasis, like lung, lymph nodes, as seen in our patient case. So although the prognosis is poor, it is essential to recognize the metastasis early to initiate appropriate management. So that's it for me. If anyone has any questions, I'm happy to answer.
Okay, so I will be talking today about our results that we obtained recently from transcriptome analysis of control and resistant breast cancer cells, which reveals potential differentially expressed genes that seems to be good, promising biomarkers and drug targets. So my name is Sirine Adham. I am an associate professor at Sultan Qaboos University in Oman. I work at the Department of Biology, College of Science. So I guess I'll give you a brief introduction about neoadjuvant chemotherapy and the resistance that forms during the treatment. The neoadjuvant chemotherapy is a therapy that is given for breast cancer patients before they go to surgery so that their tumor shrinks and it will be easily to manage in the surgery room. However, this neoadjuvant chemotherapy, we noticed that it can be like some patients, they behave to resist this therapy, and their tumors, they will not shrink, or if they shrink, they don't shrink or they don't resolve at all. And therefore, I will be only talking about the resistance formed in that setting. So this is a severe, of course, problem in breast cancer therapy. And therefore, we think that a population of cells, they resist this therapy. And these cells, they will remain in the breast tissue until the time when they will be activated again and they form tumor again. And that is what we call usually the refractory breast cancer. So the neoadjuvant chemotherapy is made in cycles, and the typical therapy that is given to cancer patients are adriamycin cyclophosphamide, alkylating agents that they interact with the DNA and they inhibit the replication. And then this is given in 4 cycles, and each cycle of this treatment is 21 days apart from each other. So, and then after that, they will be given paclitaxel, and the paclitaxel is also given in 4 cycles. And by this, they finish the course of neoadjuvant chemotherapy and they go to surgery. They will resect the tumor if it's remaining there, if it resisted, and then they will be, given another time the treatment in adjuvant setting. So neo is before the surgery, and adjuvant setting is after they do the surgery to make sure that they kill any cancer cell that remains. However, we always ask the question, how do cancer cells survive when everything should kill them? All these are very cytotoxic compounds and given. Therefore, there is certain mechanisms and pathways in the cancer cells, which makes them to be resistant and not to respond to these therapies. And therefore, we actually built this model so that the chemotherapy, that it acts on all cells in the body. And then it works as all size fits all, which means chemotherapy is given to cells that they will be targeting normal cells plus the cancer cells and so on. And our aim in doing transcriptome analysis to look for targets is to actually have something like this. So each patient will have its own T-shirt in this case, or its own treatment tailored for its specific genetic markers and transcriptomic markers. So the chemotherapy acts like that, and the targeted therapy will act like these separate T-shirts. So the aim of the work is to determine distinguishing biochemical pathways, genes that lead to chemotherapy resistance in breast cancer cells using the transcriptome analysis of patients treated and not treated. So initially, we started our project by looking at cell lines. So for instance, we have built this model, which was published in 2020 in the British Journal of Pharmacology, where we modeled the neoadjuvant chemotherapy in vitro. We had two cell lines, MCF7, very famous, representing luminal A, and the MDA-MB231 cells, which represents a triple negative. And after seeding these cells, we treated them exactly the same way the patient is treated, mimicking, timing in days rather than months, until we selected those very resistant cells to the 4 cycles of AC, or adriamycin cyclophosphamide. And also we collected and we continued the treatment with paclitaxel, and we collected the MCF7 and the MDA cells with the treatment in total. So that is something we built ahead of time. We kept early passages of these resistant cells, and we are working on them. So what we did later on, of course, in this paper, we actually spoke about how these chemotherapy resistant cells made a change in the subtype as well of the MCF7. We all know that MCF7 cells is a HER2 negative and ER positive. At the treatment with the resistance, in fact, MCF7 became HER2 positive. So that was astonishing, and we had to do several tests to confirm that. But that is not my story. My story starts here. MCF7 and MDA now, we have 2 variants of resistance. We have resistance to the adriamycin cyclophosphamide and resistance to the whole treatment, which is adriamycin cyclophosphamide and paclitaxel. So what we did was that we isolated the RNA, the total RNA from the MCF7 and its resistant variants, the MDA and its resistant variants, and we sent them for full RNA sequencing, and advanced bioinformatic analysis was done on them. We checked their quality control. We have done all the reads align it with the reference genome. We studied the expression profiling, differential gene expression, and the gene annotation and KEGG pathway analysis. So what we get is actually this. So for the MDA and B231s and for the MCF7, what we get was that we got MDA control and MDA AC treated, MDA PAC treated, which is like adriamycin cyclophosphamide, paclitaxel, in triplicate. So what you see here is 1, 2, 3, 1, 2, 3, and 1, 2, 3. So what was really something interesting is that the control MDA and the AC, they seem to have and carry more or less the kind of same differentially expressed gene pattern. However, the MDA that it was treated with all the treatment with the 3 drugs flipped, like we have upregulated genes and downregulated genes, like they're really flipping what we have seen in the AC and the control. In the MCF7 cells, we did the same also in triplicate. This is like part of the slide that I also presented in a near conference, and that's why you see like the MESCR, but that's what we got. Like in MCF7 control, PAC, and AC, here the scenario is a bit different from the MDA cells. Again, explaining that every single cell line has its genetic makeup and its RNA makeup. In this case here, in MCF7, the luminal A subtype of breast cancer, we got the AC to flip the expression pattern. Now, what does that mean? It means that we need to look at these genes and see exactly what happens at the level of real-time PCR to validate that. So this is what we got. So what we get here is the results. Okay, let me just double check one thing. So that is, Okay, to November. Yeah. Okay. So let me go back again. Yeah. So now we quantified, in fact, the genes, and we noticed again in the MDA, the all treatment, adriamycin, cyclophosphamide, paclitaxel, led to more differentially expressed genes compared to the MCF7. MCF7, the addition of paclitaxel to the treatment, it returned the number of differentially expressed genes as the baseline, which is the control. However, the number of genes that they were really expressed differentially was in the AC treated group. Okay, let me get my pointer here so that you can see better. So in MCF7, this is to remind you, as a result, the AC control have more differentially expressed genes compared to the MDA, where we find it in all treatment group, which indicates here that paclitaxel addition, which is ACP, paclitaxel addition, returned this to the baseline of the control. Okay, so that is something really interesting. So these are the number of genes, differentially expressed genes we got in the two cell lines. Now, when we looked into the KEGG analysis pathway, we've noticed that, for example, in the MDA MB231 cells, that the signaling pathway known as node-like receptor signaling pathway was very interestingly upregulated. Now, all these are top 10 significant upregulated pathways. However, we noticed only that node-like receptor signaling pathway was the featured pathway in the MDA MB231 cells resistant to AC only. So we wanted to take this pathway and the genes that they make this pathway and focus on it a bit more, because node-like receptor pathway usually is not a sign for resistance to treatment, but rather it's an innate immunity in immune cells. So what happened that we get it only on the AC treatment? This is something that we are investigating. So therefore, we took I'm only showing like few samples here. And then, therefore, I will show you how in qPCR we have got the expression of certain genes that they are upregulated in this particular cell line. So in this resistant MDA to AC, we found that in qPCR and RNA sequencing, validation of the results of an important molecule, which is known as IL-1 beta. So IL-1 beta is one marker for inflammation that seems to be increasing again in the treated cells with AC, but it decreases when paclitaxel is added. So what does that imply? It implies that, for example, if a patient is taking a treatment which is AC, at this time, maybe we can target IL-1 beta to reduce its expression so that maybe she or he, or it's actually she, will be benefit from the targeted therapy for IL-1 beta rather than just giving paclitaxel, because we know that paclitaxel in a lot of different literature, it shows that it actually enhances the metastasis. Now, in MCF7, other than MDA, we looked also on the top upregulated, significantly upregulated pathways. We found that, for example, in the all treatment PAC, which is paclitaxel, adriamycin, cyclophosphamide versus control, proteoglycan in cancer was one of those significant pathways that is not present in the comparison of AC control or PAC and AC. So again, the same thing, we have taken some of those genes. One of them was MYD88. This is the next generation sequencing data that we've got from the sequencing, and this is the validation that we did in the lab. We find that MYD88 is one of those genes that upregulates upon AC treatment as well. So what we did is that we have taken the MYD88 in both cell lines, in MCF7 and MDA, and we wanted to study the function of this gene in particular in these resistant cells. What we did was we have designed siRNA to knock down the MYD88. As you see in MCF7, the knockout or the siRNA used was not as good. However, in MDA cells, we downregulated more. And we studied different cellular features in terms of apoptosis and so on. So we found, yes, when MYD88 is knocked down, we can actually target MDA cells, although this gene was captured in MCF7. So that is something that we do cross-check between the two cell lines and the resistant variants, and we see which one seems to be a good target for reducing the expression of such a gene that usually works downstream of the NF-kappa-B inflammatory pathway. Again, this is another target for future treatment. So overall for this study, for the MCF7 and MDA resistant variants, we've noticed that node-like receptor pathway can be targeted. So it is a class of cytoplasmic pattern recognition receptors involved in metabolism and immunological response that are usually activated in innate immunity, but we found it to be present in those treated cells with AC. The same thing, RAP1 signaling pathway is another pathway that we found also in the MDA cells treated with paclitaxel and AC. And the RAP1 usually it acts as a stress adaptive survival signaling pathway. So understanding these pathways, that they were distinguished between the three comparisons, is something interesting, and that is something that we are really focusing now on our studies. So for the RAP1 signaling pathway, just to give you a brief preview, what does it do? Now we remember that this was captured in paclitaxel treated cells, which means AC paclitaxel. We know that paclitaxel stops the microtubule stabilization and affects the mitotic potential of the cells. And therefore, it actually affects the homeostasis of other downstream signaling, such as ERK and AKT, which in turn RAP1, which is like a protein present on the plasma membrane, affects the integrin and its attachment, which means extracellular matrix. So if we look at all the genes that they are involved in this pathway, and study their profiling and then targeting them to understand whether they can be good targets for treating patients who has received this therapy and became resistant to it. Now, I move on to the other part of the study. We have now employed the RNA sequencing for a panel of 776 genes rather than doing a total RNA on clinical samples. So we have from our hospital an ethical approval to do this retrospective study. So we have collected 39 patients, and they were treated differently, of course, based on their subtype. Of course, PAM50 is a subtyping that happens on the molecular level. Sometimes we could see differences between the PAM50 subtyping and the subtype that was done in the hospital. And based on that, we actually did this kind of clustering to see the heat map and the presentation of certain biological signatures that they get upregulated or downregulated. Generally speaking, breast cancer is a cool kind of cancer, which gives a lot of downregulation for genes, but we also have got a few genes that they get upregulated upon treatment. So which means we have taken these 39 samples and we looked and stratified them into treated, not treated. And we got 19 samples to have a match between pre-treatment and after treatment. And therefore, we looked at what they received, and we are trying to understand what biological signatures are more featured and more enriched based on the treatment they received. So triple negative breast cancer, they only receive neoadjuvant chemotherapy. The patients who has hormone positive, they got a neoadjuvant. And the ones that they have HER2 positive, they receive trastuzumab neoadjuvant chemotherapy. And therefore, the different biological signatures, they were different between the three treatment groups. And at the moment, we are analyzing this data by using the decision trees as mathematical model built on Python, where thanks to the computer science department who are helping us to analyze this data. So we fed all these biological signatures to the Python, and we asked which biological signature would be stratify the patients based on their response. So because we are studying resistance, so we have taken the partial responders who responded partially but not fully. And we noticed that again, BRCAness seems to be a very important splitting node to differentiate and stratify between the patients who have received different treatments. So as you see at the end of the tree, you see like Gini equals 0. That means we have good purification, good pure tree according to the features or the biological signatures that the tree picked. So for example, if there is a threshold for brightness, if the brightness was less than or equal 6, for example, this will be true for those patients who has got endocrine neoadjuvant chemotherapy. I have to note that we split the patients based on their treatment. So some received endocrine neoadjuvant, as I mentioned before. Some they only received neoadjuvant. Some of them they received the endocrine neoadjuvant and Herceptin. Some of them they received endocrine and neoadjuvant alone. So the main node was split on the most available treatment, which was in the endocrine neoadjuvant chemo group, which is 8 patients out of the 18. And therefore, if brightness was less, then cytotoxicity was also less. And if cytotoxicity is less as a biological signature, it will enrich for a lower value for progesterone receptor. So which means by the end of the tree, we have neoadjuvant chemotherapy and Herceptin, neoadjuvant chemotherapy and Herceptin, and endocrine. These patients here, 2 patients, for example, they were characterized by having more PGR. And then these patients, they also have like lower cytotoxicity and lower brightness. The patients who received only neoadjuvant and Herceptin, no endocrine, they were split based again on these 3 features, so PGR, cytotoxicity, and brightness. However, the difference between the ones that they received Herceptin, endocrine, and no endocrine was the value of PGR. So if PGR was lower than 4, it enriched this patient here, the only one. And then if it's high, it enriched these 2 patients who received all the treatment. Regarding the brightness in terms of if it's higher than 6, that means like 6 out of the patients who received the neoadjuvant alone, they were enriched here, and most of these patients, they have high brightness. This confirms that this model is actually good, because we know that triple negative patients, they will only receive neoadjuvant chemotherapy. The only sample left, which is again 7 samples, they were treated only with neoadjuvant, which are triple negative. There is 1 sample out of the 7 that had a little bit different feature, which means it had less brightness compared to the higher brightness, which is the feature of triple negative. But if it has low brightness, it had also high cytotoxicity. And if high cytotoxicity led to a low level of TIGIT, which is again immune checkpoint feature, if that is low and the cytotoxicity was high, and the brightness was low, this was again a feature of one of those patients who received neoadjuvant chemotherapy. So as we see, like based on the treatment, we can tell within one group, which is partial responders, how the different biological signature they split and how they are affected by the treatment received. So in total, we are still working on this, but this is just a model that we just built, and we wanted to test it, and it seems to work. So a decision tree might become an accurate pre-treatment triage tool. Its primary use can be to select a regimen before therapy starts, steering patients towards DNA damage intense versus endocrine immune leaning strategies. So that's again what we are still working on. And in conclusion, for the study on cells, we thought to highlight node 3 or node-like receptor pathway to be targeted for AC treated, and RAP1 is to be targeting a triple negative breast cancer treated with all the drugs, which is PAC, or which is paclitaxel AC, or adriamycin cyclophosphamide. Thank you very much for listening today. I hope I did cohere with the 20 minutes talk. This is my group here at the Sultan Qaboos University. These are my students, undergrad and postgrad students, former my PhD student, Noura, and all of them, they work together. This is a picture we captured when we had a visit from the American school to our lab to show what we do, because we receive like a Terry Fox fund that is arranged by their school. So thank you very much. And if you have questions, I'm ready to answer them.
Hello, everyone. My name is Ali Mansoursamaei. I'm a medical doctor from Shahrud University of Medical Sciences. I'm currently a general practitioner in a hospital in Tehran city, which is the capital of Iran. And first of all, I want to thank my co-authors, Dr. Forough, Sadeghi, Khalili, Wahedi, and Ateshi, which helped a lot to do this work. And also, I want to thank the executive team of the 5th International Webinar on Cancer and Breast Cancer Treatment. The title of our work is the relationship between the number of stem cells and the concentration of stromal cell-derived factor 1 with liver cirrhosis. As we all know, chronic liver disease can lead to cirrhosis and liver failure, which is a really bad complication because of the vital role of the liver in metabolism and detoxification. It can be caused by infection, alcohol abuse, metabolic disorders, intoxication, and biliary tract abnormalities. And it's interesting to know that near 4% of the global deaths are due to cirrhosis. And also, we know that liver transplantation is the only total curative option, but it is costly and limited in many countries. So we should concentrate on the liver repairment and the tissue repair of the liver for minimizing the total surgeries and total transplantation. Here we have stem cells, which are really capable cells for the repairment of the tissues all over the body. And stem cell-based therapy aims to restore liver function, and especially mesenchymal stem cells, which are highly regenerative, with highly regenerative capacity and low immunity. Also, we have a factor and chemokine press movement. It regulates stem cell mobilization. You have my voice. Shall I continue? Or?
Yes, doctor, you shall continue.
Okay, thank you. Yes, here is a STF1 factor, which is a factor that is secreted by hepatic stellate cells and sinusoidal stellate cells, which is which has contribution on stem cell mobilization, survival, and tissue repairment. Okay, in this study, we aim to investigate the relationship between the number of circulating stem cells and the serum concentration of STF1 with disease severity in
Hello,
patients
Dr.
with
Malik.
liver cirrhosis.
Yeah, sorry
Yes.
to interrupt. Your screen is not visible. Could you please check with your slides?
Okay, of course.
Yeah,
Thanks letting me know.
yeah, welcome.
Okay. Can you see it now?
Yeah, it's perfect. You shall proceed.
Okay, of course. Yes. The knowledge gap here is the limited data comparing circulating CD34 plus cells and SCF1 and the association of these factors with the liver cirrhosis severity. So we designed a study, a case control study with 15 patients with liver cirrhosis and 15 healthy normal controls. Also, the age range of the participant in our study was 18 to 65 years. Our study was done in Imam Hussein Hospital in Shahrud, which is affiliated to the Shahrud University of Medical Sciences. Also, we excluded pregnant patients with liver organ, vital organ failure, hepatocellular carcinoma, or even other cancers, patients with active infections, diabetics, and patients with uncontrolled hypertension. Also, all of our patients, they didn't use any immunosuppressive drugs within 4 weeks. Child-Pugh classification was used to assess the severity of patients with cirrhosis, and all of our patients were classified in Child-Pugh 2 or 3. And we use peripheral blood for sample collection and for flow cytometry staining with CD45 and CD34 was done in the flow cytometry part, and also for the measurement of the concentration of STF1, we used ELISA with STF1A minikit. Our data analyzed by SPSS and FlowJo, we compared 30 patients and healthy control in terms of STF1 and stem cell concentration, and also with the association of them with the disease severity. We use chi-square and descriptive statistics to show our results. As you know, we used 15 patients with cirrhosis, and we compared them with 15 healthy controls. 47% of cirrhotics and 44% of the controls were male, and 46% of all participants aged 51 to 54 years. And in the severity part, near 1/3 of our patients, our cirrhotic patients, were class B, and the other part was class C, which were near 2/3 of our patients. About circulating stem cells, we saw that the mean CD34 plus stem cells in blood was much more higher in cirrhotics than in healthy controls, near 2.8 times higher, which was significant, and it indicates the mobilization of stem cells in cirrhosis. This is expected, and we expected that because damaged cells and all tissues of the body, and of course damaged cells, secrete STF1, and it causes the migration of stem cells from the bone marrow to the peripheral blood and eventually to the tissues in need of cell repair. So this result is reasonable. And as you can see here, the concentration of the percentage of circulating stem cells in cirrhosis was much more higher. Here we have the flow cytometry plot. We compared CD34 and CD45 in patients with cirrhosis and healthy controls. And as you can see, The peripheral blood CD34 hematopoietic progenitor cells are increased in cirrhotic patients compared to healthy controls, while total CD45 leukocytes remains comparable. And the top figures are the two top figures are for the cirrhotic patients, and the bottom figures for the healthy controls. About SDF1 levels in the serum, the mean concentration of SDF1, as you can see, is 1.8 times higher in cirrhotic patients, and again, it is significant and it is expected. And also, in comparison of the severity of the disease, we saw that child PUC patients again has higher SDF1 concentration in peripheral blood compared to child B patient. And again, it was significant. And again, here is the figure that you can see the average SDF1 concentration in the cirrhotic patients and the healthy controls. An interesting result that we have was that although the SDF1 concentration in cirrhotic patients, in more severe cirrhotic patients, I mean child C patients, was higher than child B patients, we saw that the percentage of the CD34 stem cells did not follow the same algorithm. It means that the serum concentration of CD34 in patients with child B was a little bit higher than child C, although it was not significant. This suggests that SDF1, but not the circulating stem cells, stem cell count, reflect the disease progression and could be a marker for the diagnosis. Okay, in the discussion part, we have the interpretation of findings. Stem cells are essential for tissue regeneration and are mobilized from the bone marrow during injury, as we discussed. We saw that circulating CD34 plus stem cells in cirrhotic patients was much more higher than healthy controls, and this suggests an active mobilization response to the liver damage. However, no correlation was observed between the stem cell count and disease severity, and this is likely due to the failure of stem cell engraftment in the chronically inflamed liver microenvironment. Probably it is due. It is because that inflammation in the inflammation environment, stem cells are failed to be implemented in the tissue, and because of the apoptosis, their concentration would be lower in more severe patients. And this limits the regenerative potential of the stem cells. As we saw, SDF1 is secreted from the damaged hepatocytes and hepatic stellate cells, and it regulates stem cell migration, implementation, and survival. We saw that SDF1 is increased in more severe cirrhotic patients, and this was also suggested by previous works that has done. They saw that elevated SDF1 in advanced cirrhotics and proposed its use as a biomarker for fibrosis and disease progression. We can conclude here that SDF1 could serve as a potential indicator of cirrhosis progression or treatment response. We have some limitations in our study because of the small sample size, about 13 participants, and our work was done in a single center and with limited etiology range. Our cirrhotic patients were all due to the cryptogenic causes or hepatitis B caused cirrhotic. And we recommend that future work should be larger and should be done in multi-center studies. And also CXCL11 also should be compared as well as other biomarkers, and we should try SDF1 as a marker for the prognosis, for the progression of the disease, or even for the diagnosis of the liver cirrhosis. Okay, my presentation has been ended. You can contact me if you have any question or matter. We can discuss with each other, and you can follow my LinkedIn and Instagram as well. Thank you.
I'm Alan Olin, independent researcher from USA. Dear colleagues, during next 20 minutes, I will introduce you to a novel method of finding non-infectious diseases. And when we'll go over result of its application to breast cancer, we'll discuss unique combination of physiological changes which causing breast cancer. Let me just slightly move it if it's possible. Okay, so in the next few minutes, let me give you some context to the problem solved here. The information here may be a bit subjective, but its purpose to just give you some context. First of all, why do we need a method of finding non-infectious diseases? There are at least a few next reasons. Unknown pathology of many non-infectious diseases, large number of research exists, but there is no definite conclusion of what's causing many non-infectious diseases. Only about breast cancer, it's estimated that there are hundreds of thousands of research available. Next reason is huge discovery time for non-infectious disease causes, and in some cases, the knowledge is not complete. Any significant progress in this discovery of non-infectious diseases causes has happened after many years of research and often by luck. We still don't know and don't understand entirely multiple sclerosis, for example, Alzheimer, etc. There are many non-infectious diseases which pathology is still unknown. For example, Stephen-Person syndrome, Crohn's disease, etc. Challenges in drug creation also exist to treat or cure non-infectious diseases, as we don't understand a full picture of non-infectious disease pathology. There are other reasons as well. So how presented method addresses some of the needs for it and some of the challenges in creating it. Method requires small number of selected studies, which already exist. It's often around 40 studies is sufficient to make a conclusion of disease pathology. I stress 40 selected studies, not just overall. Method is using existing research to solve question of pathology with high precision, which can be improved by adding to analysis more research. Method allows a short discovery time for non-infectious disease pathology, and due to this, allows to uncover disease pathology for many non-infectious diseases in months, not years. Method applies simple mathematically based laws to complexity of human biology. Method is using complexity of human biology to its advantage. Method allows to computerize the discovery of non-infectious disease pathology, as it's based on algorithm which mathematically derived. I stress mathematically derived. The future computer application may require to enter list of certain research as input and would give an answer what are disease causes. Multiple other challenges can be addressed with the method. You can see my screen pretty well, right? I assume. Let me move to the next slide. Now let's take a look at the foundation of the method. The method has been created using a model presented already published article. This model, which confirmed empirically, is introducing two important relationships: A, between disease frequency and the number of physiological changes, which are causing it. Number B, relationship between non-infectious disease risk like OR, RR, due to some factor, and number of disease-causing physiological changes which are created by this factor. As this method is using concept of precise science, we would call them as two laws. So on the screen, you can see the first law is law of disease frequency. It states that a non-infectious disease frequency incidence rate in the population is determined by a number of physiological changes which are causing this disease. The more incidence rate, the less number of physiological changes which are causing it. I repeat it so you can understand better. A non-infectious disease frequency incidence rate in the population is determined by a number of physiological changes which are causing this disease. The more the incident rate, the less number of physiological changes which causing this non-infectious disease. Second law you can see on the screen is law of disease risk, which states that a risk of non-infectious disease under the action of particular factor is determined by a number of disease-causing physiological changes these factors creates. The more disease risk from this factor, the more physiological changes are caused by this factor. I repeat this one because it's going to be important for your thorough understanding. So one more time. Second law is law of disease risk, which states that a risk, a non-infectious disease, under the action of particular factor is determined by a number of disease-causing physiological changes the factor creates. The more disease risk from this particular factor, the more physiological changes are created by this factor. Application of first law. The law of disease frequency has shown that practically all non-infectious diseases are caused by a unique combination of 2 to 6 physiological changes beyond 1 sigma, coexisting at the same time. Let's take a look at the example here. For example, lung cancer and bronchus cancer. Incident rate 28.5 per 1,000 people per year in New York. So according to first law, it's created by 5 physiological causes. Second example is multiple sclerosis. Incidence rate 303 per 1,000 people per year in Germany. So according to this law, it's created by 4 physiological causes acting simultaneously during a particular time. Next, let's move to next slide, please. Second law allows us to decide the disease causation criteria. It takes risk factor as a K. In this case, K equal OR minus 1, or RR minus 1. For better understanding, currently, you can treat K as OR and R. It makes more sense and more simple to understand at that point of time when you can do your necessary calculations. First criteria is what the risk factor is a disease causation factor, which changes one physiological parameter beyond approximately 1 sigma if K value of this is 3.55 plus minus 50%, if you can see here. Second criteria is what risk factor is a disease causation factor, which causes 2 physiological parameter changes beyond 1 sigma. And it's if a value K is 19.67% plus minus 50%. There are also disease causation criteria for pre-physiological changes and more. It's important to know the disease-causing factor acts by changing a set of physiological parameters approximately beyond 1 sigma interval. In the table below, we can see a frequency of factors which are causing the disease. You can notice you can notice that majority of disease-causing factors are changing only one physiological parameter. So most often you see this change. 3.5 OR, roughly for you, it's really K, and it's causing one physiological change, and that's most often observed in practice. Second one is 19.67. It's observed less often, but also occurring. Knowing already that non-infectious disease requires at least two physiological changes, at least two physiological changes beyond 1 sigma, we can see that such a factor cannot cause this disease as standalone, because it requires at least two factors to cause an infectious disease. Our disease-causing factors need to change additional disease-causing physiological parameters beyond 1 sigma in the right direction. Let me move to the next slide. Knowing that two laws we discussed, disease causation criteria and experimental data, we can now explain genetic mechanism of non-infectious disease pathology at high level. On the diagram, you can see example of non-infectious disease pathology for disease with two physiological changes. Disease-causing factors are affecting multiple physiological parameters of human body. They make disease-causing physiological changes by impacting a set of only two physiological parameters, as well as go beyond approximately 1 sigma interval. Multiple disease-causing factors are affecting the same set of two physiological parameters, as you can see here, this one and this one. For example, you can see what on the peak, what the disease-causing factor 1 and disease-causing factor 2 are impacting the disease-causing physiological parameters on the top. This one and this one impacting this physiological parameter. For example, multiple disease-causing factors are affecting the same set of two physiological parameters. In that case, for example, you can see on the peak what disease-causing factor 1 and disease-causing factor 2 are impacting the disease-causing physiological parameter on the top. Disease-causing factor 3 and 4 are impacting disease-causing physiological parameter at the bottom. Only these two physiological changes are important for triggering of this specific non-infectious disease. Let me move to the next slide. On this slide, we discuss analogy, which explain in simple terms the mathematical mechanics. So the process of non-infectious disease pathology for disease can be illustrated with a padlock analogy. For disease with 4 physiological changes, we can see next padlock with 4 wheels. Each wheel represents a disease-causing physiological parameter for some specific non-infectious disease. I stress, each wheel represents a disease-causing physiological parameter for some specific non-infectious disease. On the left side, the padlock is closed, and it means the disease doesn't exist. The body is healthy. Now we can open one wheel on this padlock. We can open one wheel on this padlock, which means some factor is changing physiological parameter beyond 1 sigma in the right direction, up and down. In this if 3 other wheels, which are still closed, will not allow to open the padlock, and this means what a non-infectious disease cannot start. Now, if under action of multiple factors, we unlock 4 wheels, and this way we change all 4 disease-causing physiological changes beyond 1 sigma in the right direction, then a padlock will open, as you can see on the right side of the diagram over here. The opening of all padlock means a non-infectious disease with 4 physiological changes has started. Now, it doesn't matter which disease-causing factor will turn the wheel of a padlock. As long as this set of disease-causing factors which turn all 4 required wheel non-infectious disease will start after some time. The causation of disease is not optional. I stress, it's not optional, it's a must, as long as we keep a padlock open long enough. From here, you can see what if you put a lock back in place and turn off at least one wheel, you may give enough human body a chance to heal from this non-infectious disease. In our words, analogy states that a non-infectious disease resembles a padlock with few wheels. Let me move to another slide. So before you start using method, obviously there is a question, what exactly going to give it to you? So let's discuss it quickly. So it's going to give you a number of physiological causes which trigger non-infectious disease under investigation. Second, it's going to give you a factor causing disease, a list of found disease causing factors. Third, it's going to give you a factor force, a number of physiological changes whichever disease causing factor is creating. It's going to give you physiological causes, unique set of physiological changes which are causing non-infectious disease under investigation in all these changes, if all these changes approximately beyond 1 sigma interval and coexist long enough. Fifth, factors physiological impact, a table of factors which are causing the disease and the connection of all disease-causing physiological changes they create. Factors combination, a table of factors which show how to create multiple combination out of them. So they must cause non-infectious disease if coexist long enough. It gives you hypothesis, a strong hypothesis of disease pathology for non-infectious disease under investigation. Next one, it's going to give you supporting evidence, available research which support the physiological changes found to be disease-causing for non-infectious disease under investigation, so it's verifiable. Prophylactical measures we can derive from it, ability to introduce prophylactic measures by knowing disease, causation factors, and physiological changes. Treatment cure way, ability to introduce medications which treat, cure when infectious disease under investigation, enough to affect them with medication. Let me move to the next slide. Let me just try to close it out. Okay. So let's take a look at the diagram describing how method works. We have set of experimental data and algorithm which method is using to process this data. Data consists of few different groups. First group is data on incident rate of disease. Second group is multiple research about risk of disease specific non-infectious. Second group is a multiple research about risk of specific non-infectious disease. Third group is data on physiological changes observed in the presence of different risk factors of a disease. Algorithm consists of a few main steps which include, you can see it over here, which include usages of first law, criteria based on second law, which we just discussed, mechanism of mathematical match using tables, validation and post-processing of preliminary results, creation of factor physiological changes dependencies, creation of disease-causing factors combinations. As we can see from a diagram, first step usually is to determine a number of disease-causing physiological changes which are causing the disease using the law of disease frequency. During second step, we determine the set of disease-causing factors by passing available data in disease risk factors of disease risk factors through disease causation criteria, which we just were able to see. The found disease causation factors are then used in list of all physiological changes observed in their presence, and they also to execute a match of this physiological parameter across each of disease-causing factors using specially populated tables. Once a match has been executed, it will give us a list of potential physiological parameters which are causing a disease preliminary matrix PM. The list of preliminary matrix PM is then corrected, adjusted using number of physiological changes found and the hard condition found in disease causation criteria. The corrected adjusted list is then creating final list of disease-causing physiological changes, which is final matrix PM. Using the final list of disease-causing physiological changes in a matching table, we build a disease-causing factor, disease-causing physiological relationship, and then the disease-causing factors combinations. Further matrix PM can be used to build a hypothesis of disease pathology. We need to notice what the algorithm processing support verification of its results using existing medical research and disease criteria to assure and eliminate possible human errors during its usage. I'll skip this few slides. I'm just going to display them so we can go over if you get a chance. Now, quickly example of some of the steps which you're going to be using if you start using this method. Now, let's take a look at the example of some steps taken during processing according to the method. You can see some non-infectious disease with incidence rate of 80 cases per 1,000 people. Of course, it's just an example. We get the number of disease-causing physiological changes as using law of disease frequency. In step 2, we know that the non-infectious disease has a 5.7-fold increased risk in presence of such factor as social phobia. This is within a range of one first disease causation criteria for OR, which is 4.5 plus minus 50%. So we conclude the social phobia is disease causation factor for this disease with impact to one physiological change. Now in step 3, we see how a disease causation factor we determined, which is social phobia. We find that physiological change, which present at the time when this factor exists, is decrease in BDNF levels. And example, step 9 shows how after steps execution, we get matrix PM, which is basically a list which consists of 2 physiological changes, which were determined using a law of disease frequency. The matrix PM has 2 parameters which changing beyond 1 sigma should trigger this non-infectious disease if it's simultaneously present. So I stress only if, in this example, if disease causation physiological parameter, this one and this one, both present for quite a long time, is going to trigger a disease. Okay, now I'm going to quickly show you the example of matching table. On this slide, you can see how we build table 1 and table 2. On the left, we list the disease-causing factors we determined for this non-infectious disease. You can see it here. In the tables headers, we list physiological changes related to these disease-causing factors. It's over here. Using letters R, we mark relationship between a specific disease-causing factor and the related physiological change. As it was explained earlier, such a table serves as a matching mechanism. I stress as a matching mechanism. In this table, we find matches between physiological parameters belonging to different factors. I stress, in this table, we find matches between physiological parameters belonging to different factors. We mark the matches with bold rectangles. It can be seen here. This is a match, and this is a match for the same physiological parameter. In this case, reduction of GABAergic inhibition, and our physiological parameter, low BDNF. So we find a match.
Hello, Dr. Helen.
Yes.
Sorry to interrupt. You have 2 minutes left for your presentation.
Sure.
Okay.
Now, using breast cancer, using this method, we analyzed the breast cancer. Here to provide some basic result of this analysis. First of all, it was determined that breast cancer is caused by simultaneous presence of 4 physiological changes beyond 1 sigma. You can see over here. What's triggering breast cancer is coexisting of these physiological changes. Increased number of DNA strand breaks beyond 1 sigma, TNF alpha should be increased beyond 1 sigma, leptin level should be increased beyond 1 sigma, estradiol level should be increased beyond 1 sigma. Let me move to the next slide. Now let's take a look at the diagram which explains how breast cancer is triggered according to research which I just mentioned. In the center of the diagram, we can see 4 disease-causing physiological changes which require for breast cancer, for breast cancer causation. All physiological parameters, increased number of DNA strand breaks, increased TNF alpha, increased leptin level, increased estradiol level should be beyond 1 sigma approximately to trigger breast cancer. Now we can see how multiple factors can trigger breast cancer. For example, increased number of DNA strand breaks can be caused either by low total carotene or presence in BRC, BRC2 genes. You can see low total carotene impacting increased DNA strand breaks, as well as BRC, BRC1 gene mutation also causing the same increase. This is how gene mutation is impact breast cancer triggering. So if a woman has the same gene mutation, but they can control multiple of DNA strand, number of DNA strand breaks within 1 sigma interval, we will be able to compensate for these gene mutations. In similar way, you can see what TNF alpha increases is caused by the presence of cystic breast disease or premenopause woman has BMI over 26, 65 kilogram per meter square. You can see it here. TNF alpha impacted by breast cystic breast disease and EVA different factor, premenopause woman with BMI high at 26.65. So same physiological change, but different factors can cause it. Doesn't matter which factor causing. Maybe hundreds of different factors causing the same TNF alpha increase, and it's going to cause a breast cancer. Let me quickly move to another slide. So as I showed you, that method allows to build a breast cancer and our disease, non-infectious disease hypothesis. So we can briefly illustrate it here. I was done an example of breast cancer. On this diagram, you can see we show all physiological parameters which are causing breast cancer. We just discussed one. If they coexist and change beyond approximately 1 sigma interval. Now, using known research and our knowledge of biochemistry, monocytes, and etc., we need to connect these physiological parameters to create a complete process of breast cancer triggering. On the diagram, you can see what leptin level helps to increase number of DNA strand breaks. Estradiol level helps to damage DNA by creating adducts. TNF alpha doesn't allow it to restore damage of DNA. It's just an example of possible biochemical relationship found in existing research. This not at the end create hypothesis of breast cancer. So as an increase beyond 1 sigma number of DNA strand breaks cannot be repaired, increase beyond 1 sigma TNF alpha level, and increase beyond 1 sigma level of leptin, where leptin level reduce energy capability of a breast cell, in particular for repair processes. And along with additional level of DNA mutations, you adduct created by high estradiol level deprive a breast cell from DNA repair capabilities required to compensate for normal DNA degradation process. And overall, the DNA damages and mutations accumulate beyond control. This result is in triggering of breast cancer. In short, the disruption of DNA damage and repair homeostasis leads to breast cancer. Let me quickly show you principle of indifference. As we discussed the method to find disease causes by experiments, we propose to use a simple principle which can be observed in physiological process. When regulating its own homeostasis, separate physiological systems of the body, indifferent to side effects of these regulations, we can see a principle of, we can call this principle of indifference. We can observe this principle in multiple cases. For example, if brain needs to increase blood pressure to improve the supply of nutrients and oxygens in it, it's indifferent to the fact that heart may not be able to sustain this high blood pressure. That's you can find our examples over here. And for further study, you can find my work in these articles. I'm just going to display it here. And you can contact me at email alanolan@gmail.com. Thank you for your attention.
thank you so much for having me. My name is Dr. Nia Bailey. I am based out of Philadelphia, PA in the USA. My presentation is based on my dissertation, Federal Healthcare Reform, Breast Cancer, Outcomes. That's the table of contents. I won't go through it, but that's what we will be talking about today. So I am a radiation therapist. I'm currently at work right now, so I'll try to go fast as I am at work and I have to get back, but I appreciate this opportunity. I'm also the president of Bird Cancer Foundation. What we do is connect the individuals, community, and patients to the resources and tools that they need to prevent, treat, survive cancer, and everything in between. I also have lupus, and I do have a cancer gene, BCL6, which increases my risk of lymphoma. Now, all the facts in this presentation was based off of my dissertation in 2020. So some of the data is a bit old, but I just wanted to preface that. I got my doctorate, like she said, at Westchester University, and I studied public administration. Breast cancer is the second leading cause of cancer in the United States. And the current guidelines are to get a mammogram starting at the age of 40 if you are at average risk and starting at the age of 40. But the problem is younger women are being diagnosed with breast cancer at younger ages. And in fact, Black women under the age of 35 years old are getting breast cancer twice the time of other women and die of breast cancer 3 times as often. So the current guidelines of average risk does not reflect what is currently going on in the world, but in particular with the United States of America. Now, average risk just means that you don't have a family cancer history, but the issue is familial cancer or genetic cancer only makes up between 5 to 10% of cancer. So there's a greater percentage of the population that are not quote unquote average risk, but do and should probably get screened. The purpose of the study was to examine women's early experiences with their providers after their experience of being diagnosed with breast cancer, identify barriers to early screening and treatment, and recommend policy and program reforms to improve survival outcomes, because maybe we cannot eradicate cancer, but if we can remove the sting of it, if we can provide early detection, that saves so many lives. So my research questions were, what are women's early experiences with their providers? And do these experiences create barriers in timely treatment? So in timely treatment plays a huge role in early detection. So as I said, young women face higher stage diagnosis and more aggressive disease. Black women are 42% more likely to die of breast cancer, and these are statistics in the United States. The overall 5-year survival rate for breast cancer diagnosis is 81% for Black women and 91% for Caucasian women. 54% of breast cancers in Black women are diagnosed at local stage compared to 64%. As I mentioned, Black women are more than twice likely to be diagnosed with advanced breast cancer and have a higher risk of recurrence. And there's a thing called triple negative breast cancer, which disproportionately affects them. And we know triple negative breast cancer, there's 3 components that aren't there. And what makes it so hard to treat is because they're not there. And usually these women aren't enrolled in clinical trials. Therefore, the medicine is not reflecting what needs to be treated within their bodies. The significance also points to insurance and screening guidelines, as I mentioned, which can worsen the outcomes. Incidence rates. So this is, as I said, based off of my 2020 dissertation, but 123.6 per 100,000. And at the time, 5.6 cases of breast cancer were diagnosed under the age of 40. Now, statistically, while that may not look like a high percentage, it is a high percentage and based in 2020 because one breast cancer diagnosis is too many. And here's that graph of the incidence rates by age group. So we have less than 40 years old, and then the category of 40 to 49, 50 to 74, and 75 plus. And now these numbers have increased. So the barriers that have been identified, screening age guidelines, like I said, 40 for average risk, insurance cover limitations. So we know that primarily if you are not of age, it's very hard for the insurance to cover the testing that is needed, and that presents some barriers. The lack of breast health and education and awareness, and then also something called medical apartheid, so the distrust in the medical system, such as the Tuskegee experiment, Henrietta Lacks, or South Carolina sterilizations. These the distrust in medical system and the medical apartheid really creates a huge barrier in the trust between the community and the healthcare system, which also delays in treatment. And in terms of policy context, there's always different recommendations that confuse the public. And we talk about the coverage gaps of women under 40. So yes, I talked about genetics and family cancer history, but as I mentioned, only make up between 5 to 10% of known genetic cancer, which is so confusing because if you are of the public and do not have a medical education or background, you think that, hey, nobody in my family has cancer, I don't need to be checked. You don't understand that you still need to check your body. You still need to know you're normal. So these guidelines can be very confusing when they differ and when the numbers sometimes say otherwise. So there needs to be equity in mammogram and diagnosis access, diagnostic access. So in 2020, these were the screening comparisons. So it looked like no clinical breast exam, which is absolutely asinine to me because the patients that I treat, they have found their cancer. So clinical breast exams are very important, not only for them to do, but for their providers to do. And as you see the different variables between the ages and how many times you should get a mammogram and the age range. And I always say, if there's something called a pediatric cancer, then no woman is too young to get breast cancer. We treat patients who are 5 to 10 years old. So while the numbers should not matter, whether you're 1 year old or 99 years old, you should know you're normal. You should know your family cancer history, and you should seek help if you find something that is out of your normal. The methodology of my treatment, or my dissertation, was a qualitative study. I explored the lived experiences in the individuals, and the themes coded were through ethnographic analysis, so observing their natural environment, understanding their cultural, their behavior, and social interactions. So what I found was, yes, indeed, there were barriers included in due to lack of insurance, delayed screening. Provider communication and consistencies is very important to have a patient-provider relationship. And when you do not, the barriers are astounding. Limited knowledge of family cancer history and genetics. Some people do not know their family cancer history because they are adopted, or maybe they just don't know, and because they don't seek the help and understand that although they do not know, they still should have a patient-provider relationship. And it's also very important to understand emotional and social challenges, caregiving roles, stigma. Okay, yes, I find out I have breast cancer, then what? My life is still happening, and there's things that need to be set up so that I can be supported in my diagnosis and through survivorship. So recommendation, should we have a mammogram age? I understand that a 5-year-old should not get a mammogram, but my mentor, who is a breast oncology surgeon, she has a patient as young as 17 years old with breast cancer. As I said, the youngest that I've treated was 24 years old. So if you are in the community and you hear 40 years old of average risk, you are not typically going to seek help because you think that you aren't going to get breast cancer because you are not of that age. So education is paramount. Insurance addendum. We need to cover screenings if you're not 40 years old, if you're less than 40 years old. If your provider writes a prescription, the insurance should cover it, because that means that there's some investigation that needs to be happening to figure out what's going on in your body. I always tell my patients, they are the CEOs, the chiefs of their body. You know your body better than anyone. So if you see there's something wrong, seek help. There needs to be a requirement of breast health in clinical settings, educational settings, and community settings in middle school and high school. we talk about health. So they always talk about the variety of health, but we need to talk about in the school settings of breast health. That's so very important. It should not be taught when you're in your 20s. It should be taught very young so that you have a standing of what needs to happen and what you need to look for. And very important to integrate genetic testing and counseling, but also talking about insurance coverage as well, talking about life insurance, really telling your patient that before you get genetic testing, you need to get life insurance, and because that impacts if you have a positive genetic predisposition, that impacts your life insurance. Talk about clinical trials and integrative wellness. Western medicine and integrative therapies can work in conjunction. They can be married. So talk about all of those things. You can get surgery, you can get chemo, you can get radiation, and you can get ecotherapy. You can practice mindfulness and breath work. All of those things are very, very important. There needs to be equitable access to screenings, and we need to reduce racial disparities in triple negative breast cancer. I said I'm in the United States. Delaware ranks #1 for Black women being diagnosed with triple negative breast cancer, and they think it's due to the environment. They think epigenetics has something to do with it when the environment sort of alters your DNA, and between other things like stress, between other comorbidities, between smoking and not getting enough rest, and all of the things that play a huge role in the diagnosis of cancer and outcomes. And also build trust through culturally competent care. We are all different. We all speak different languages. We all have different beliefs. So that is very important for providers to understand when educating the community and also talking to their cancer patients. So in conclusion, it's very important to save lives. Early screening is so paramount. Women's experiences reveal gaps in access, education, and policy, and reform is essential to improve breast cancer outcomes for young women. Breast cancer does not discriminate based on age, race, ethnicity, language, or any of the things. So it's very important that we improve outcomes for all women, but in particular to my dissertation, young women. So I want to acknowledge those who helped me in my dissertation, my mentors, participants, family and friends, and who inspired and supported the research. This is my contact information, and thank you for listening to my presentation.